He prefers to only come out at night. He was moody and ill-tempered. He fears and avoids the light. Did Dracula suffer from photophobic migraines? When you think of Dracula, you might imagine a blood-sucking vampire that only comes out at night, can transform himself into a bat, and sleeps all day in a creepy castle. Now, I'm not suggesting the patient in this case study I'm about to share with you has fangs or lives in Transylvania, but rather his photophobic migraines were so severe that, like Dracula, he had a significant aversion to light. As we know, the stories and movies go so far as to suggest that if Dracula is caught in sunlight, he will turn to stone or into dust and perish. This results in Dracula having both a fear and an avoidance of light. This case study is about a 15-year-old patient that experienced such significant light sensitivity that even the term photophobia doesn't quite capture his struggle and distress with light. Whether it was sunlight or artificial light, computer screens, or handheld devices, his intolerance to light and fear of its dire consequences were more aligned to that of Dracula than that of a typical teenager growing up in sunny Brisbane, Australia. Just take a moment and put yourself in his shoes. Can you imagine? In Brisbane, Australia, in the state of Queensland, which is lovingly referred to as the Sunshine State, it's actually sunny most days of the year. In a recent Google weather search, Brisbane is renowned for its great weather and perfect temperatures. There is an average of 283 days of sunshine per year. This can be interpreted as 80% of the year, it's just another sunny day in Brisbane. Average temperatures vary between 20 and 28 degrees with clear blue skies. Now imagine you are so light sensitive, so significantly photophobic that you can't go outside. You can't enjoy this beautiful weather, and you're 15 years old. You can't ride on your bike or skateboard or play in the park or go to the beach or just do fun kid stuff outside. What a waste of this beautiful sunshine, and more importantly, what a waste of the formative childhood years when you should be playing outside. I would hope that wherever you've grown up, you've had an opportunity to enjoy nature and being in the sunshine. Now imagine that you get such severe migraines that being in the light has dire consequences. Now consider how this would also affect the whole family. Planning camping trips and picnics in the park and outdoor gatherings are all met with difficulty and resistance. His mom mentioned that even long car rides would take their toll, and it would be a struggle and sometimes a conflict if they had to drive for over an hour because of the glare of the outside world into the car window. I met this patient about a year ago, and during our initial consult, when I asked him what his main concern was, he said, "The world is too bright." He explained he'd been having headaches and light sensitivity for the past 10 years. Since he was around 4 years old, his mother confirmed that she had noticed he would rub his eyes and avoid light and seem distressed. The patient explained that he had daily headaches, and when the intensity was bad enough, he would refer to these as migraines. The light sensitivity was also daily, and he explained he would rather ride his bike at night or stay in a dark room than be in the light. He noted he had withdrawn from lots of social and sports activities and was spending more and more time in isolation. Whoa! Talk about a Dracula in the making. Now these photophobic migraines were starting to affect his schoolwork as the use of technology was becoming more and more prominent in the classroom. His lessons were being taught using whiteboards, on PowerPoint, using tablets and computer screens, all of which was aggravating and triggering headaches. He explained even playing video games or watching TV could be an issue. And wow, for a teenage boy, this was catastrophic. It was all just getting to him. He was in pain, had daily headaches, was frustrated, irritated, and felt his life was so restricted. His quality of life had deteriorated due to his headaches and severe photophobia. Maybe Dracula had it right. Maybe living in a creepy castle all day long was the best way to manage this, as nothing else had worked so far. So what was this patient's history? What was his diagnosis? What treatments have they already tried? Well, over the past 10 years, this patient had been diagnosed with 3 different diagnoses. The first one was at the age of 6, was IRLEN syndrome. The second diagnosis was attention deficit disorder at the age of 12. And the third diagnosis at 15 years old was hereditary migraines. IRLEN syndrome. As a physiotherapist, I was not that familiar with IRLEN syndrome, and I had to do some research to learn more about this disorder. It is also referred to as Mears-Irlen syndrome, scopic sensitivity syndrome, or visual stress syndrome. It is described as a perceptual processing disorder, not an optical problem. In other words, it's not the eyes, it's the brain. Therefore, it's the brain's inability to process visual information correctly. At the age of 6, our patient's pediatrician suspected a light sensitivity disorder, and with the consensus of a behavioral optometrist, they came to this diagnostic conclusion. I also learned that this can be a lifelong condition and may be a barrier to learning and information processing throughout his life. The main symptom is light sensitivity or photophobia. Other symptoms can include eye strain, fatigue, and headache. The diagnosis fit the photophobic symptoms for our patients, and he was treated accordingly with specific precision spectral filters, or as he referred to them as, funny glasses. He also was managed using a variety of light-altered devices and special colored paper. This mitigated his light sensitivity. However, his headaches continued to be an issue. He was unable to complete progressively demanding schoolwork and assignments because of his headaches, and his grades were suffering. His mood was irritable, and he was frustrated, and furthermore, he was being isolated and possibly bullied for wearing these funny glasses. Subsequently, he refused to wear them as he got older. Furthermore, the glasses and altered devices seemed to only be partially helping with his symptoms and may not have been getting to the source of his problem. His headaches, mood, and behavior were troubling, and his scholastic performance was struggling. The progressive worsening of scholastic performance, paired with continued health deterioration, led his mother to seek further assistance, and a second diagnosis was provided. Attention deficit disorder, or ADD. Now at 12 years old, a pediatrician and psychologist arrived at this diagnosis. Again, as a physiotherapist, I had to learn a little more about this condition. I had heard of both ADD and ADHD, attention deficit hyperactivity disorder, but it wasn't clear to me as to how they were different. There has been some dispute over the name over the past 3 decades, and as it turns out, these terms are often used interchangeably. Our patient more accurately fit the criteria of attention deficit disorder because he lacked the impulsiveness and hyperactivity behavior more commonly associated with ADHD. In ADD, the main symptoms are inattentiveness, easily distracted, and restlessness. It presents as a chronic condition of attention difficulty, which often begins in childhood and can persist into adulthood. Poor school performance, having low self-esteem, troubled relationships, and irritable mood are all symptoms of this disorder. Our patient was not doing well at school, and he was unable to focus on learning tasks and had poor performance during tests. He was also having emotional outbursts and becoming more and more withdrawn. As you may know, the main treatment for attention deficit disorder is pharmaceutical as prescribed by his doctor, and often this course of medication is prescribed over a 6 to 12-month period. Unfortunately, this intervention was feeble for my patient, as the side effects from the drugs were devastating. He explained he felt foggy or couldn't think clearly, and his mother described him as grumpy or dopey. Furthermore, his headaches progressed in frequency and intensity. He was becoming more and more worried or anxious about them. Now in high school, his grades continued to decline along with his self-esteem. He was reporting symptoms of increased anxiety, and his family doctor then prescribed anti-anxiety medications to try and alleviate these symptoms. Pharmaceutical drugs were altered, doses were modified and increased. However, this was again not helpful for our patient, and he continued to suffer. His quality of life was deteriorating, the treatments weren't working, and he was left feeling devastated, dejected, and drugged. And he continued to have headaches. Treating the symptoms of ADD and anxiety didn't seem to be resolving his symptoms or getting to the source of the problem. So his mother decided to try another medical professional opinion. The third diagnosis was hereditary migraine, and this was made when he was 14 years old. Perhaps this diagnosis was because of his mother's medical history, as she had migraines, so the label hereditary was attached to this diagnosis. Now, according to the International Classification of Headaches Disorder in the 3rd edition, the criteria for hereditary migraine is non-existent. That's right. To clarify, in the over 300 types of headaches listed, hereditary migraine is not part of this comprehensive list. Now, this is not the first time I've heard patients refer to themselves as having a hereditary migraine as their diagnosis. So it was really interesting and surprising to learn that hereditary migraine is not an official diagnosis. Another issue about this label was the effect this had on the family. A diagnosis of hereditary migraine was severely impactful for our patient's mother. Her son's suffering was now all her fault, and there was nothing that could be done about it because it was just unfortunate genetics. She had lived with this burden of migraines most of her life and is familiar with the struggles and suffering that came with them. She knew how difficult some days could be and how she now passed this on to her son. With this diagnosis, he was trapped, and she had feelings of fault, blame, and guilt. She did not wish for her son to suffer as she has. She explained that this was the only diagnosis that led her to tears. This was the only diagnosis in which she cried herself to sleep that night. The term hereditary was a mislabel, yet very powerful word for this family. I felt the need to explain to our patient and his mother that this designation should not have been used, and there are much more fitting terms for his type of headache. Migraine with aura. So let's choose something that is in the International Classification of Headache Disorders. And we can refer to our patient as having migraine with aura, as it's a much better fit. Migraine with aura is described as a recurrent headache disorder manifesting in attacks lasting 4 to 72 hours. Aura symptoms usually precede and can accompany the headache and made up of transient neurological symptoms. Typical characteristics of the headache are unilateral location, pulsing quality, moderate to severe intensity, aggravated by physical activity, and an association with nausea and or photo or phonophobia. Our patient was prescribed some migraine-specific medication, and unfortunately, again, this was not effective. He reported feeling foggy and groggy and having little to no relief from headaches. He explained the migraines had increased in frequency and severity, and he was struggling with the pain and felt this was a losing battle. Enough was enough. Of their own volition, mother and son presented to the Specialty Headache Clinic Physiotherapy Clinic as self-referred patients and were willing to try something new. So although over the years I've treated a lot of patients suffering with migraines, I really felt as though I was their last hope. This family had spent the past 10 years searching for answers. They had already tried a multitude of interventions, and they had been unsuccessful in one way or another. They were both seeking answers, desperately looking for something to improve, something to bring them out of the dark. This patient's history was filled with mysterious clues and puzzle pieces that didn't quite fit together. The treatments already tried were reasonable, yet his condition did not improve. How did all this fit together for this specific patient? What could I do differently? How could I help? Would physiotherapy be the answer? The initial subjective examination. As a physiotherapist, I started where most of us begin, with observation. Sitting before me was a 15-year-old boy, slouched with rounded shoulders, his hair covering his eyes, his hat pulled down over his face, and an indifferent expression of boredom that most teenagers seem to master. Subjectively, our patient explained that his headaches were daily, as was his photophobia, and as the headaches progressed in severity, he referred to these as migraines. The migraines could occur 4 to 5 times per week. The headaches he described as throbbing, pulsing pain with pressure behind his eyes. He felt all types of light was a significant trigger, and he could have light sensitivity and neck pain before the onset of a headache. The head pain was across the forehead and behind the eyes. He also explained that the headaches could alternate sides and swap equally between the left and right sides. The headaches would last for hours, and he would have to go and lie in a cool, dark room to get some relief. Sometimes pain medication would take the edge off, but typically most of the day would be spoiled. The key features for us clinically is the alternating nature of this headache, the area of pain, the frequency of both the headache and the migraine, and the intensity of pain, as well as the photophobia and the duration. These pieces give us something to measure and reassess if the treatment is having a desirable effect. Now on to our objective measures. Range of motion. Cervical range of motion was unexceptional. He had full range of motion in every direction. The craniovertebral stability tests were normal, and there were no abnormalities on the vertebral artery assessment. Investigative scans were also clear. So far, nothing glaringly obvious. On to palpation. Palpation of the upper cervical spine revealed the spinous process of C2 was deviated to the left. There was local tenderness and hypomobility of the left C2-3 facet joint. The transverse glide of the C2 spinous process was from left to right, more hypermobile compared to from right to left. Constant pressure of the left atlanto-occipital OC1 joint reproduced familiar head pain, and there was gradual resolution as the pressure was sustained. In other words, bingo! This suggests the relevancy of the upper cervical afferents in this headache presentation. We have a potential source of a sensitized brainstem or trigeminal cervicogenic nucleus, which can focus physiotherapy treatment on the upper cervical spine to treat the source of his headaches. Yay! According to the International Classification of Headache Disorders, a headache that is reproduced and reduced with sustained pressure to the upper cervical spine is not described in this criteria. And although his symptoms are similar to migraine with aura, he doesn't satisfy all of the ICHD criteria. For example, his head pain is bilateral, and it can alternate sides. His photophobia is constant and not transient. Nor does he satisfy the criteria for other types of headaches, such as migraine without aura or cervicogenic headache. The alternating behavior of the headache swapping sides is important clinically, but yet again only partially satisfies the diagnostic criteria. However, after everything they had been through, maybe a label or a diagnosis is not that important. When I explained to them that there is likely a cervicogenic dysfunction and the neck is a significant factor in our patient's headaches, they both looked at me as though they could have told me that years ago. When I explained that there is also a potential sensitized trigeminal cervicogenic nucleus involved, they were not interested in what it was called. Only physiotherapy could provide some relief. Treatment in accordance with the specific Watson approach protocol comprised of a manual intervention addressing the rotation of C2 and the head pain referral from the OC1 atlanto-occipital segments. This was complemented with advice and education, a retraction home exercise, as well as a treatment plan with expected outcomes, reassessment factors, and some answers to their questions. So what happened? Did it work? Well, not to leave you wondering, yes, it worked. Regular treatments with multiple sessions were effective. After the initial session, he reported being migraine-free. Wow! Yes, I was pleased and pleasantly surprised. I can honestly tell you that typically it takes more than one session, at least a handful of sessions, for a patient to be migraine-free. This was really impressive and almost too good to be true. I was cautiously optimistic and thought, maybe there's a placebo effect. However, now a year later, I'm convinced. He has still not reported having a migraine since that initial session. Wow. Here's a table to summarize our physiotherapy sessions. Not only did the treatment serve to decrease the intensity, frequency, and duration of both the headaches and migraines, it also decreased his light sensitivity. The technique was specific and effective within 5 sessions over 30 days. The second session was 4 days later, and the patient reported he had had a headache, but not a migraine, the day after treatment. This lasted a few hours and eased with pain medication. He felt the trigger was due to the whiteboards in school. However, on subsequent days, the use of the whiteboards did not trigger a headache. Notably, his mother reported improved mood in her son's demeanor and how happy he now seemed. 1 week later, the patient and his mother returned for their third treatment session. He reported again not having any migraines, however had one headache after spending the afternoon at a skate park. Interestingly, the glare off the concrete and other metal obstacles were not as limiting or triggering light sensitivity as much as they had before. He explained the headache was mild and eased spontaneously later that evening, and he did not have to use any pharmaceutical intervention. The following week, the patient and his mother came in for their fourth treatment session. He reported having one mild headache lasting about half an hour. He explained that typically he would have to lie down in a dark room, but since the intensity was mild, he decided to tough it out. Again, it eased spontaneously. He also noticed the change to light sensitivity and explained that sunlight was not triggering his headaches. Glare from certain devices continued to feel bright, however, no headache was triggered. Overall, we were both impressed with his treatment progress so far. The fifth session was 2 weeks later. He explained his eyes had been feeling better, less light sensitive, no longer sore, red, or watering. He related that he was able to focus his attention at school and was doing better on tests and assignments. He could read from the whiteboard and use a variety of devices without headaches. He also reported going outside more often and enjoying the sunny Brisbane weather. Skateboarding with friends was a daily adventure, and it was clear he was generally happier. The sixth session was 2 weeks later, and the patient explained he was feeling awesome. During our session, I noticed he was sitting in the glare of the window, and I pointed this out to him, expecting him to change seats. However, he just shrugged and explained it was no big deal. This was a compelling moment for me. It was the first time I had seen him sitting with the sunlight right into his eyes. It had been 6 weeks since our first treatment, and the outcome measures were significantly improving and being maintained. He was able to complete an assignment using PowerPoint and told me he received a top grade. He continues to go outdoors and participating in school sports activities. Also, he'd had a haircut. This was compelling as the patient liked to use his hair to cover his eyes, but now he would tuck his hair behind his ears and fully expose his face. The next sessions were a month to 2 months apart, and as you can guess, he continued to feel better. The headaches progressively decreased in every outcome measure, and still no migraines. The light sensitivity was no longer a factor. The patient reported improved outcomes in his studies, and his grades reflected this improved performance. He explained the lack of light sensitivity allowed him to continue to use devices and participate in outdoor activities, and the sun is now fun and no longer a trigger. Also, he went on a thrill ride in a theme park, and he went on a variety of fast-moving, spinning rides, lots of flashing lights, bright lights. He did not experience any headache or light sensitivity. What a change! He noted that previously the car ride alone would trigger, but now he did not have any concerns and enjoyed a fun-filled thrill riding day. On our 10th session, he confessed that he used to suffer with headaches so intensely that he would punch himself in the head. He was so frustrated and angry living with these headaches. He remembered when he used to sneak pain medication in his school bag and felt reliant on drugs. And now he doesn't take anything at all. He expressed he used to live with increased anxiety, fear of headaches or migraines, limited by light sensitivity, and generally frustrated by his life. He said the past 6 months have transformed his life, and he is no longer afraid of light. He's no longer afraid to participate. He uses devices, and possibly, most importantly, he reports improved feelings of happiness, decreased anxiety, and how grateful he is that physiotherapy was effective and has changed his life. Part of the purpose in sharing this case study, besides sharing his story, is to analyze how he can put the pieces of his diagnostic puzzle together and figure out how each diagnosis compares and contrasts. The symptoms of IRLEN syndrome, attention deficit disorder, and migraine can seem isolated. However, upon closer examination, they share some interesting attributes, and although it may seem challenging to treat this constellation of symptoms, we can look at the bigger picture to consider a common source. Let's take a look and shine a light on each of these 3 diagnoses. A patient with migraines with aura typically has symptoms of photophobia, followed by pain, and therefore can be affected by a variety of visual stresses, which is the core of IRLEN syndrome. Now, shining a light on IRLEN syndrome, we know that visual stress during tasks such as reading, combined with photophobia, affects cognitive performance, and therefore may be interpreted as an attention deficit disorder. When we shine a light on attention deficit disorder, we recognize this is a cognitive processing dysfunction that is affected when we have an attention impairment, and also when we may be experiencing pain, such as suffering from the pain of migraine. So what do these conditions have in common? There's strong scientific evidence that a hypersensitized brainstem is at the source of all of these conditions. IRLEN syndrome. As we discussed, it's a processing disorder of the brain, not the eyes. It's estimated that 14% of the population has IRLEN syndrome, and of those, 46% have learning difficulties and reading problems. Research has begun to support that there may be a link between headaches, migraines, and IRLEN syndrome. Researchers of IRLEN syndrome have recently found that visual factors such as glare and other visual stress can contribute to migraines and photophobia. This research suggests that visual cortical hyperexcitability is hypothesized to be responsible for visual stress, and photophobia is a key trigger in migraines, especially migraines with aura. Recent neuroimaging studies demonstrate that there is increased neural activity in response to visual stimulus, which resulted in photophobia. Using pattern glare visual stimulus, this research demonstrated visual cortex hyperexcitability in people with light-sensitive migraines. This is consistent with the hypothesis that in migraine, the brainstem or trigeminal cervicogenic nucleus is sensitized and hyperexcitable. Optometrists may prescribe precision spectral tinted filters, or funny glasses, were clinically indicated for specific conditions in which pattern glare may occur. This includes migraine, photosensitive epilepsy, stroke, traumatic brain injury, concussion, whiplash. There is strong scientific evidence for increased presence of visual stress in these conditions, suggesting again a cortical pathophysiology mechanism. Also in optometry, it is widely accepted that the treatment for IRLEN syndrome is these specifically selected filtered lenses. This is best practice for this condition. These funny glasses were found to be beneficial in mitigating epilepsy, post-concussion syndrome, and reducing migraines. However, this was only for a few migraine patients. These glasses can be used prophylactically and are inexpensive, safe, and free of side effects. Depending on your style, they can look somewhat fashionable. Now let's consider attention deficit disorder. The prevalence of this disorder affects 8 to 12% of children worldwide. Core diagnostic features of attention deficit disorder include having a short attention span, being easily distracted, difficulty organizing tasks, feelings of anger or frustration, and appearing forgetful or losing things. You'll note that headaches, migraines, and photophobia are not part of the list of ADD symptoms. However, there is some recent research that suggests an overlap of these conditions. One study with over 4,000 university students evaluated the association of attention deficit symptoms compared to those with no headache, those with tension type headache, and those with migraine with aura. They found there was a significant association between attention deficit scores and those with the headaches. Particularly in the migraine with aura group, there was the strongest association of the hyperexcitability measures of neural activity. This demonstrates a powerful link between a hyperexcitable brainstem in those with attention deficit disorder and with migraine with aura concurrently. Another study compared 62 children with headaches to 52 children as controls without headaches. In the clinical headache group, 14 had migraine with aura, 29 had migraine without aura, and 19 had tension type headache. They used a visual reaction test as an assessment of visual impairment. The results of this study demonstrated the clinical headache group had slower reaction times compared to controls. Interestingly, the 3 headache groups did not significantly differ. Therefore, in this study, regardless of the type of headache, the results confirm the presence of an association between attentional impairment and headaches. The finding that the 3 clinical groups did not show significant differences in attentional performance supports the hypothesis that migraine and tension headaches form a continuum that may share the same pathophysiological mechanisms. Tension type headache and migraine may not be separate entities, but rather different expressions of the same condition, a sensitized brainstem. Furthermore, this overlap may be a hypersensitized brainstem, and this could predispose children to attention deficits and headaches, which may impact learning and daily activities for their lifetime. There is significant research to support the use of pharmaceutical intervention in those with ADD. Psychostimulants are the medications of choice in treating attention deficits. The 2 types that are most commonly used are amphetamines and methylphenidates, with the brand names such as Ritalin, Concerta, and Adderall. However, the dosage and frequency of medications may have to be adjusted early during the course of treatment. Therefore, possibly pharmaceutical intervention could have been effective, yet for our patient, the side effects were debilitating. Migraine with aura. As mentioned, the International Classification of Headache Disorder describes migraine with aura as recurrent attacks, as we discussed, and the aura is fully reversible and is typically visual or sensory. Usually the aura develops gradually and is typically followed by the headache. In other words, migraine is a chronic neurological disorder characterized by multi-phase attacks of head pain and a myriad of neurological symptoms. The population prevalence of migraine is variable, and I was unable to find a definitive percentage. Focusing on children and adolescents, I found data that in children aged 3 to 7 years old, the prevalence of migraine is 3%. It was 8% for those aged 7 to 11 and 15% in teenagers. Another study reported 71% of people aged 12 to 15 years have at least one headache every 3 months, and 40% have at least one headache or migraine per week. So the research is not clear, and depending on how migraine is classified or how the variables such as intensity are defined, the symptoms may be interpreted in interesting ways. However, the prevalence in young people is significant. There is widespread agreement that the migraine condition is underpinned by sensitization of the neurons in the trigeminal cervicogenic nucleus. A general hypothesis in the pathophysiology of migraines is the hyperexcitability of the brainstem and the input of cervical afferents. As we discussed, research suggests that cortical hyperexcitability is hypothesized to be responsible for visual stress, which can be a significant trigger for migraines with aura, also resulting in photophobia. Besides a sensitized brainstem, hypothesis also includes a lack of inhibitory influences, which ordinarily modulate sensations of glare and light-induced pain. This is supported in the research by investigating activation of neurons in the brainstem in response to a bright light stimulus and pain response. Therefore, sensitization of the trigeminal cervicogenic nucleus could result from two pathophysiological mechanisms, one being facilitatory, as noxious afferents from the cervical region, and the second due to dysfunction in the central inhibitory controls. In other words, triggers like visual stress with a sensitized trigeminal cervicogenic nucleus in the brain is primed for a migraine reaction. Lack of inhibition coupled with noxious cervical afferent information in a sensitized brainstem is a migraine in the making. As a result, we have light triggering migraines with aura. Treatment is also variable, and prescription drugs specifically for migraines, such as triptans, have been shown to be effective for this condition, as well as other pharmaceutical interventions such as anti-epileptic drugs, antidepressants, antipsychotics, anti-inflammatories, nerve inhibitors, muscle relaxants, and even dietary supplements. Psychological interventions such as cognitive behavioral therapy and pain management strategies have also shown to be somewhat helpful for migraine with aura. And of course, we can't forget the role of manual therapy, like massage, chiropractic, osteopathic, and specifically physiotherapy techniques to the upper cervical spine. Physiotherapy as manual mobilization techniques to the cervical spine in the management of IRLEN syndrome, attention deficit, and migraine has not been described in the available literature to date. It is reasonable and logical to consider cervicogenic dysfunction has the potential to sensitize the brainstem. Modulation of cervical afferents has been shown to desensitize the trigeminal cervicogenic nucleus in migraineurs. It is irresponsible not to examine the upper cervical spine in patients with headaches. Therefore, utilizing physiotherapy manual techniques for patients with headaches or migraines seems appropriate, particularly when alternative options have not shown convincingly good results. In our case study, we described a successful manual treatment approach in a patient with multiple diagnoses, each with a common source involving the sensitization or hyperexcitability of the brainstem. For our patient, as a young child, his symptoms and behavior had to be interpreted by his parents and doctors. He may have been unable to adequately express his head pain, and the behavior of rubbing his eyes and avoiding the light was interpreted as an eye or light sensitivity issue. Initially, his mother explained she tried to make changes around their home, such as dimming lights, adding blackout curtains, putting up shades in the car. Having him wear sunglasses also didn't really seem to help. Headache pain can be difficult to describe for some adults, so as a child, his true symptoms may have been misinterpreted. The medical diagnosis of IRLEN syndrome seemed a good fit, and as this was focusing on his photophobia. As an adolescent, a diagnosis of ADD also seemed logical, as this focused on the issues he was having scholastically as well as emotionally. His irritable mood may have been due to his headaches, which in turn exacerbated his inattentiveness, resulted in poor grades. Furthermore, the side effects of the drugs were overwhelming and made his cognitive issues worse. As the headache symptoms persisted and their intensity increased to migraines, this now became his priority and his main health concern. Due to his mother's own headache history, the diagnosis of hereditary migraine was made, and the impact of this was overwhelming. It was time for a change, for them to take matters into their own hands, which led them to seek physiotherapy as an alternate direction of treatment. In physiotherapy, not only did the treatment serve to decrease the intensity, frequency, and duration of both headaches and migraines, it also decreased his light sensitivity. This was somewhat unexpected. The migraine ceased after the initial session, definitely unexpected. The technique was specific and effective within 5 sessions over 30 days. The headache progressively decreased in every outcome measure. Not only did we focus on the manual technique, but also education, advice, communication, and empowerment were part of the treatment sessions. Taking the time to listen to their story, explaining to both the patient and his mother the treatment technique, educating them about the possible sensitization of the brainstem, and describing expected treatment effects and timelines resulted in success. The patient reported improved outcomes in his pain, also his cognitive studies, and emotionally, he reported improved quality of life. The significant decreased light sensitivity allowed him to live life outdoors and without headaches, and he was simply happier. Of course, the improvement in his quality of life for both himself and his family was very compelling. Finally, something had helped, and the physiotherapy intervention to treat the upper cervical spine was effective for this patient. Symptoms of migraine, IRLEN syndrome, and attention deficit disorder can converge, and it can be challenging to correctly treat a patient with these symptoms accurately. The medical model has limitations, and timelines of treatment effects can be quite long, such as there is a wait and see approach over weeks, months, even years. In the meantime, the patient can feel confused, frustrated, and overwhelmed with multiple competing diagnoses, and uncertain of treatment effectiveness. Migraines and headaches have a myriad of comorbidities, and symptoms reflect an escalating pathophysiological sensitization process. Patients suffering with headaches often have yellow flags of psychological disorders such as depression and anxiety. They often have concurrent metabolic issues, sleep disorders, cognitive deficits, light sensitivity as seen in photophobic disorders, and possibly other syndromes. Key learnings. So what did I learn from treating this patient? Firstly, I had sympathy for this patient and everything the family had been through over the years. This led me to value the importance of implementing a treatment timeline with objective reassessment factors to measure outcomes rather than just treating indefinitely. The cause and effect techniques of physiotherapy in the management of headaches utilizes much shorter timelines to determine effectiveness of treatment, and there's less risk of side effects. As physiotherapists, we often know if our treatment is effective in a relatively short period of time, and especially in the case of migraine sufferers, when a patient has gone through quite a journey before even trialing physiotherapy, we want to know if we can help. The patient's journey can be quite dramatic, and we never know what they have already been through before making that initial visit. Often, enough is enough, and they are looking for relief. Another key learning is the importance of language and communication. The language we use, the way we explain the diagnosis, how we explain our assessment, treatment, and what treatment expectations all play a role for these patients. In this case, the word hereditary was quite devastating. Although the other diagnoses also have a genetic predisposition, because IRLEN and ADD are not called hereditary IRLEN or genetic ADD, the association and the impact is much less dramatic. We know that words such as degenerative and disease frequently get used with minimal thought. However, this may have quite an impact on the patient. In migraine, there are those referred to as migraine sufferers and those referred to as migraine survivors. I know which term I prefer. In physiotherapy, we are lucky because if our treatment is effective, we usually know sooner than later. We can measure our results subjectively and objectively and be accountable to reassess our treatment plan and modify as needed on an individual case-by-case basis. In this case, we saw an immediate result after one session. However, it typically might take a little more than one session. Pharmaceutical interventions often take much longer to demonstrate effectiveness. In the meantime, manual therapy can be beneficial while you wait. Now let's bring Dracula back into the story. The title of this presentation is, Did Dracula Suffer from Photophobic Migraines? Well, Dracula had an aversion to light and was photophobic. We know he avoided people, especially during the day. He was antisocial, possibly depressed or anxious. He was known for having an ill temper and being moody. He certainly didn't look very healthy and was quite pale, likely a vitamin D deficiency. And he had a very limited diet, mainly consuming iron. He also had food intolerances, especially to garlic. And with those canine fangs, he likely had a temporomandibular dysfunction. And there's no doubt he had an aura about him. Let's also assume he had headaches or migraines. So do his symptoms satisfy the criteria for photophobic migraines, or specifically migraines with aura? Again, let's look at the International Classification of Headache Disorders as a guide. Remember, there are over 300 types of headaches to choose from, and possibly Dracula's symptoms could align with more than one type of headache. I'm sure this Count Dracula would enjoy counting which headaches are relevant to him. Number 1. Let's start with migraines with aura. Yes, as we discussed, he does satisfy the criteria, especially as aura symptoms include combinations of photophobia, fatigue, increased pallor, neck stiffness. This type of headache has recurrent attacks and if left untreated can last a lifetime. Number 2. Headaches attributed to psychiatric disorder. This diagnosis is based on an evaluation of specific personal history and physical examinations. It also states that primary headache disorders such as migraine, episodic tension type headache, and especially chronic tension type headache are often comorbid with psychiatric disorder. Conditions such as sleep disorders, post-traumatic stress, social anxiety, and ADD should be carefully assessed in people with primary headaches to consider the burden in the prognosis of this type of headache. Wow, this could fit for our Count Dracula, and for most patients with headache for that matter. Number 3, headaches attributed to fasting. This is described as mild to moderate, non-pulsating pain occurring if fasting for at least 8 hours and is relieved after eating. This could be a factor for our count since he only feeds at night and he might be hungry for a number of hours. Here's another one, number 4, headache attributed to temporomandibular dysfunction. This headache tends to be unilateral and is most prominent in the areas of the face and jaw and associated muscle tightness. Well, as mentioned, we can guess with those fangs, prominent jaw muscles, and biting of necks, he likely had some kind of jaw dysfunction. Number 5, there's even one called headache unspecified. This is a headache with characteristic features suggesting that it is a unique entity. It should be used only in situations where information cannot be obtained because the patient is dead, unable to communicate, or simply unavailable. This is sort of an all-encompassing term. It could also match with our Count Dracula. Let's just say there's lots to choose from in this headache classification guide, and not every symptom has a diagnosis. It seems almost pointless to put a label on Dracula, and possibly for my 15-year-old patient. As we know, it's important that the upper cervical spine be considered as a source of disorder and included in the assessment and treatment for all those suffering from headaches. I wonder if Dracula had the opportunity for physiotherapy, would he have been the same character? Also, it's important we consider the source of headache to be a sensitized brainstem. Even though there are over 300 types to choose from, a sensitized brainstem is also not one of them. In an effort to pigeonhole headache patients into specific criteria, we may miss the bigger picture. Not every symptom perfectly fits the diagnostic criteria, and not every patient needs a specific diagnosis. The convergence hypothesis allows us to consider each type of headache as a sensitized brainstem condition and simplifies headache to a common disorder. So how is our patient doing now? Well, he's still in high school and learning a trade in construction and road maintenance. I now only treat him as needed, and he refers to our sessions as a tweena tweak. I haven't treated him for over 3 months. Our most recent session was in May of this year, and he is continuing to thrive. He was wearing a high visibility uniform, reflective garments, and safety gear, including a hard hat. He had his hair tucked behind his ears and was pleasantly telling me about his day in the sun, learning to use a variety of tools and equipment like grinders and jackhammers. He rides his skateboard daily and enjoys time with his friends, hanging out at the skate park, or playing computer games. Doing all of this would have been nearly impossible without our successful outcome. He continues to be migraine and headache free and is no longer photophobic. He continues to be an inspiration, and I now have another migraine patient to treat, his mother. There was a stage when his future looked bleak, and he would have been considered unemployable. Possibly, he could have been Dracula's apprentice. But I'm happy that the specific physiotherapy to his cervical spine was effective, and for now, more than ever, his future looks bright. Thank you for listening and for joining this symposium online. I'd especially like to say thank you to Dean and Jane Watson, the research team, my PowerPoint specialist, Glenn Browning, the help of my editors, the Manual Mente team, and a very special thank you to the patient of this case study and his mother that gave me permission to share this interesting story with you.